So today I start to teach you about glycosylation. So you have to just switch back to your, I don't know, high school mood, and then look at these glycans. So glycans are sugar chains. And so there is a sugar code, and it's so awesome. It's a color code for each sugar, different sugars. So, for example, this blue is glucose, it's cane sugar. Galactose is yellow, it's milk sugar. Mannose is cranberry sugar, that's green. So whenever we are teaching you about glycosylation or a specific type of CDG, we always say, like, what kind of structural abnormalities. Don't make pictures of me like like from the ground. Like you know, it's all. You should do it from up there. Then I'd look much better. So, what is a glycan? A glycan is a sugar chain, and as you see, these different sugars, according to the sugar code, are put together as a real chain or as an antenna, and it's attached to a protein. And this protein is just swimming somewhere, like our hormones are swimming in our blood, or your liver function enzymes would swim around in your body, or coagulation factors. So it's just a protein with a nice sugar antenna, but it can also attach to your cell membrane. So you just imagine your cells inside of you. For example, your gut is covered with these sugar antennas. So then the cell membrane, the cell surface, would like hold onto a protein, and there will be a sugar chain on top. And different structures. You see the sugars are built differently. So how this happens? So you actually have like a factory. You grab the first sugar, your body has enzymes. Enzymes are active proteins which are doing something in your body, building something or breaking down something. So here we are building. So each step here is an enzymatic step. You have the first sugar, then comes the enzyme, puts the second sugar on top, and then comes the next enzyme, puts the next sugar on top, and you see there's variation. Which sugar comes? It's all thought out, so there is a plan. It's not random. You make the same structure for a certain protein. You use the same sugar structure. So it's coded, it's genetically coded, so you're born with either normal sugar chains or abnormal sugar chains. And then each step can theoretically go wrong. So you can imagine how many different CDGs there are. Actually, we say more than 100 types are known. So, what happens when glycosylation goes wrong? So these are proteins with the sugar chains. They won't work properly without the sugar chains. So if you miss those sugars, the protein is there, you can measure in blood, but it's not functional. Or not functional enough, not good enough. So, abnormal organ development. We see in our children that their cerebellum or their brain structure is not totally good. That's because the glycosylation is essential for normal embryological development. We see a lot of hormonal disturbance like hypothyroidism. There are patients with growth delay because the growth hormone function is also related to good glycosylation. We see low blood sugar levels. There are immunological problems. Immunological problems are for several different reasons, because the fighting proteins which are getting to the bacteria and grabbing them in order to make the dead bacteria eaten up by our killer cells, our immune system. They are also sugar chains. But also the cells have these sugar chains to sort of signal, ooh, bacteria are attacking. We should go there and grab them. So immune problems are also common in CDG. Welcome, welcome. We see bleedings in surgery. Many of the patients have coagulation factors which are low or not functioning good enough. It's always tricky because when you measure the proteins, you don't know if they are just too low indeed, or we measuring it wrong because the glycan antenna is not on top. But many patients have coagulation problems when they go under surgery and they bleed extensively. And we just talked about this with Lynn, that in the European population we see a lot of thrombotic events, especially in our adult patients, and less in let's say between the age of 4 to 18. The very young patients have sometimes very bad thrombosis, and the older patients. And there are muscle problems as well. And this is all because those proteins are missing their right antenna. So there are more than 100 different types of CDGs we know, and that number is continuously growing. And now I teach you how we diagnose this disease. And when you're totally enough, when you had enough of me with all the biochemistry, you just cry or you act like you are hungry and you just walk out. Because now I teach you how you can set up a test to diagnose CDG. So here's a patient with so-called type 1 CDG, and most of you in this room have, or your children have type 1 CDG. We have one patient with a type 2 CDG, and we have one special patient who has type 1 and type 2 at the same time. So let's see type 1 CDG. You see here a gel. So when you run a gel, if this is your protein, and these are the sugar antennas. You learned already. That's milk sugar. That's cranberry sugar. Remember, it's our antenna. Normally, transferrin is a protein which has 2 antennas. Hugging is hungry already. And has 4 negative charges. And what happens? What happens that if you miss an antenna, you miss the negative charges. So if you do diagnostics, this is a control, has the 4 antenna, and then when we are missing an antenna, then you have a little bit of the 4, because it's never like all or nothing. You never have a glycosylation disorder which totally would clear out your glycans. You wouldn't be able to survive. So you always have some glycosylation, just not enough. So you see some of the normal, but you see also that 2 negative charges are here, and some of the test results show that there are proteins which are totally missing the glycans. They are totally empty. So actually you just run this gel and you show your glycosylation abnormality. So remember, type 1 CDG is missing a whole antenna. Compared to type 2 CDG, we will see this is a completely different pattern. It's like a letter. The reason for that in type 2 CDG, we have so-called truncated glycans. So the sugar antenna is missing sugars at the end. And that can vary. As you see, some of the glycans on that protein have 3 negative charges, and then you can have a more severe disease, and then you can have just 2 negative charges, or you can miss almost all the end sugars. And depending on that, you will have 3 negative, 2 negative, 1, or nothing at all. So it's a very different kind of disease, type 2 CDG. And this is really important to understand when you will learn about how can we approach treatment. So you're thinking like, oh, why I have to learn this? But actually there is a thought behind this. We will use all this knowledge to understand what kind of therapies are out there for us. I'll show you a really cool picture. There is a more modern diagnostic approach in CDG when we just use a spectrometer to measure the amount of sugar available on the proteins. And then the normal peak is that transferring with the 2 antennas and 4 negative charges. That's a healthy situation. But then, on B1 CDG, which is a type 2 CDG, you see that this big peak, it's there too. So children have normal antennas. They have proteins with totally fine, full antennas. But you see a big peak appeared here on the spectrum, and these are all truncated antennas. They're missing the end. See? These peaks. So this is a cool method to get some blood and then put in the spectrometer, and you actually can see in type 2 CDG, you see which sugars are missing. And some of the therapies are based on these findings. We see missing sugar, okay, we should do something about it. So I have this slide and it's not even complete. It's like just a wash list of all different features which are all possible to have in CDG. It's like so many different organs and symptoms that maybe we shouldn't even go into this. I just want to show you that actually most of the features, most of the symptoms are treatable. They are not curable, but treatable. And there are only a few symptoms we cannot successfully treat. So actually a doctor doesn't have to feel too bad when we are taking care of CDG patients, because with the knowledge we developed in all these years, we know the risks, we know the common problems, and we can take care of most of the problems in CDG. Okay, the sugar code. So this is Sugarology. You like it? I see all these enthusiastic faces, especially Jenna is really into biochemistry. So this is the protein. I need my antennas, otherwise I cannot function. And here's the sugar code, remember? So now it's getting really complicated. But I was thinking about the patients who are coming here, and I just wanted to show you guys, all of you guys, where is the actual biochemical problem in your child's disease. So let me just get through this. So you have these sugars, like monos or glucose. They have to be brought into your cell. So you eat it, it's taken up from your gut, and it circulates in your blood, and then it's taken up by the cells. Then you can use it for glycosylation. So it goes into the cell. And here is this machinery, this fabric. I just showed you how step by step we are building this sugar chain. So where does it go wrong? This is PMM2 CDG. As you see, here's the monos. This is very early in the whole glycan machinery. It's really at the very start, so it has a very significant effect for the whole thing. If you cannot make this step, you cannot make any glycans. You will miss all those glycans on your protein surfaces. So PMM2 CDG or CDG1A is a disorder where you cannot activate your cranberry sugar to be available for all of your glycan chains. Patients have mostly a low muscle tone, and that comes from different reasons. It's not muscle proteins which are glycosylated, receptors between nerves and muscles communicating. There are many different reasons for that. Balance problems and squint are really very common features. Many of our patients have seizures. Autistic features haven't been described in CDG1A for many years, because the patients are usually happy and content and easy to take care of. But actually they have a need for structure. They need preparation for any change. There are certain behavioral aspects which are autistic. Still, most of the patients are delightful to be with because of their personality. Feeding difficulties, I'm sure we'll talk about that, and the hormone abnormalities. As they go to adulthood, we have somewhat changed pattern, clinical pattern. They might develop spasticity, which is really difficult to deal with because that, together with the balance problem, that could be really a problem to keep mobility, and the neuropathy. So when the nerves are not working fine, the muscles don't get the stimulation for working. And even though you worked on those muscles for years and with physical therapy, you might lose those muscles when the nerves are not sending in the stimulation. That's a problem for adults. It's not easy to deal with. Scoliosis and osteoporosis, losing bone density. Also a very significant problem in many of the adults. So by the child age, you have to think about certain things and try to prevent these before they actually get it. So the second disease I wanted to show you is so-called SRD5A3 CDG or 1Q. This is a very interesting disease because actually there are these fat arms which are carrying the sugars in the synthesis, and making these fat arms are not functioning well. And the problem in the CDG is very similar to 1A because it's also missing the startup of glycosylation. It's very early and very severe. Patients have balance problems and speech delay and vision problems, and some of them have very severe skin disease that's specific for this disease. So the next disease I wanted to show you is ALT13 CDG, and I actually have a very cute picture coming up. This is a horrible CDG. We always thought that's one of the most severe ones. And actually you see that the problem is also very, very early. Remember, this was PMM2 CDG? So actually you can bring in the monos, but you cannot put this very early sugar chain further to accept the first monos. So you end up with stuck again. You cannot make any glycan chains. So most of the patients described so far had profound developmental delay. They never learned anything. They just laid there seizing and no contact, a lot of bleeding, thrombosis. Really one of the most horrible, especially the seizures, are usually intractable. You cannot take care of them. So in the recent years, we found 3 patients, 4, with the mild end of the spectrum. And we were not really understanding, like, how is this possible? Like, how can, like, most of the people so far so severe, and now this is like a new era? So actually, we just learned that the ALT13 protein has several isoforms. And this is very interesting. So actually, when you have a genetic code, and then you read that code, you make the protein. You can make different proteins from the same code. You can start the reading here or here or here, and then you can, from the same code, you can make different proteins. And some of the patients who are lucky with their mutation, they can make an alternative protein from the leftover code, and that compensates for the missing function. And this happens in other types of CDGs too. So this could be also an idea for future therapies. Okay, now comes the most complicated one. And this is 11B1 CDG. Maybe this is not the most complicated, maybe the second most complicated. So this is a type 2 CDG. And type 2 means that it's not making the glycans. So you saw all these pictures and you saw how we are actually making the glycans. This is a next step. This is fine-tuning. This is actually cutting back the glycans, and that's really silly. Like, why did you make the glycans and you go back, totally cut it back to this and start to build again? And then finally, you have your well-known double antenna already. But in this disease, you have this step starting to cut back the monosis, it's missing or it's not good enough. And then you're stuck with that incomplete glycan, and you will miss the sugars at the end. So remember I told you truncated glycans? You have the glycans, but they don't have the happy ending. They just have like one antenna or two randomly. So remember I showed you this picture? Here you see, you couldn't cut off this, so you cannot finish your antenna. This is a very different disease. Usually patients have no problems with coagulation or hormones or bleeding or thrombosis. Their liver is usually just fine. They have mostly just learning problems and sometimes behavior problems, speech delay. And some of the patients are autistic. About like 2 out of 20 are severely autistic and difficult to learn to speak. These are two cuties from Australia. They had a very rough start, and now they're developing much better. You see that the facial features are very different from the CDG1A patients. Okay, and now I'm proceeding quite well. If you're still with me, here's the last disease, PGM1 CDG. And I told you that this is a crazy CDG because it's a mixed CDG. It's type 1 and type 2 at the same time. So patients are missing glycan antennas and they are missing sugars at the end. So this is a very important enzyme also at the very beginning of the glycan chain buildup. And this biochemical step has effect on other parts of the metabolism as well. So here are some of our patients, and as you see, they are beautiful. They're really very cute. Most of them have very severe hypoglycemia, so low sugar that the patients have to stay on continuous tube feeding, because if you just stop feeding them for a moment, their sugar goes down to unmeasurable and they would seize. That's one of the most severe problems. The other one, that they have a developmental problem when they are born, and they have either a cleft palate, you can see into their nose cavity because the palate is not closed, or they have a bifid uvula. Their uvula is not close together, and that's a very subtle sign. You can recognize this disease. Many times they have a flat face, a flat profile, but they look a little bit alike, I think, because of the head shape, but awesome cute. So low blood sugar level, hormonal problems, bleeding disorder in some of the patients that was very significant during surgery. When they tried to repair the cleft, they had like very significant bleeding. Okay, so rounding up my talk, what do we have to offer? Well, it's still symptomatic treatment. And since patients are so different, we have to tailor that treatment for each patient individually. So in my experience, the earlier you start with physical therapy and occupational therapy, the better outcome it will be. So this will be an important part of our meeting to talk about that, and we'll have a lecture on these issues. Seizure control is very important, and some CDGs it's not possible. That's really horrible. Speech therapy is very important. My patients always ask me, like, my kid is 7 years old and still can't speak. Would that mean that she or he will never learn to speak? That's totally not true. We had patients who started to walk at 5 years. We had patients who started to talk at 10 years. The potential is in there. You have to go for it. We'll talk about treatment maybe in the platform session. I think one thing I always tell my patients, adequate hydration. CDG patients, they have issues with food, they have issues with liquid. Many times they don't want to drink. That just drying out can cause very severe consequences like thrombotic events or stroke-like episodes. Hormone supplements, vitamin supplements, tube feeding. Many of our patients need tube feeding, although having a GE tube is also a big risk, because every time we do surgery on a patient with CDG, we are taking a huge risk because of all these other factors which are not good enough. Bleeding, infection, fluid balance problems. So we only want to do surgery on our patients when we must. Okay. So what do we have out there as therapy for now? We can really say that's working. So there is CDG1B. I didn't go into that disease today because we don't have patients present today. But that's a problem with activated monos availability. And in this type of CDG, so this is not CDG1A, but 1B, in that type of CDG, we are able to use monos, the cranberry sugar, to treat the disease. And you will hear a little bit more from Taylor about that, because that's something we also considered in 1A, and then she will give a little bit more research information on that. But in this disease, 1B, monos can almost cure the disease. The only thing I want to mention here, that although that protein is empty here in CDG1B, and when you give the monos, that will slowly fill up and it will appear again and the proteins will be all nicely glycosylated. But those patients they are born with a liver abnormality which can actually get worse and worse during the lifetime, and they can have liver failure even though they are totally treatable. So there are hidden, how should I say, traps on the way. We're thinking we are taking care of this part of the problem, but there are many other problems on different levels in CDG. And then we will hear about galactose therapy. That's a new therapy we use in more than 4 different CDGs with quite some success. And in these disorders, we have truncated glycans, so missing sugars at the end. And when we push in the yellow sugar, it makes it possible to build and finish up the glycan chain. It does make fantastic difference in coagulation factors and sometimes in anticoagulation factors and liver disease. We learned that galactose actually does a little bit more than that. So galactose does get into the glycan machinery and will help to finish up the sugars, but it seems that galactose has an extra fantastic effect. It upregulates glycosylation in certain disorders, makes a push, and some of the CDGs react to galactose, although they are not missing that yellow sugar. Still, it seems like it can push the glycosylation towards a better outcome. So that's research. That's not routine therapy. For actual routine therapy, we have these disorders which already have shown that they get much better on galactose, and there are research going on about possible use of galactose in other type of CDGs. So actually what we do, and we collect patients for this study, that we have certain laboratory abnormalities we would like to improve on galactose treatment, and the block in the glycosylation can be anywhere. If we see these abnormal functions, then we have a marker to follow whether the galactose does anything with the glycosylation. Taylor will teach you about that. And then in our study, what we are doing is we have an upload protocol. We give galactose powder to our patients. That's a powder which has a very mild taste. It's from milk sugar. And then the patients get a lower dose for 6 weeks. Then we increase it for double dose and then triple it in the last 6 weeks. And during this period of upload, we see whether the biochemical changes, the glycosylation screening results, the coagulation stuff, the liver function, whether it shows an improvement. If the improvement is not spectacular, we are not pushing this galactose idea further. So we do see improvement in most of the patients we treat, but we need significant improvement in order to put a kid on a diet. So we are still enrolling for this study, and so far we enrolled 18 different patients, and then all the PGM1 patients showed a brilliant improvement, 2 TMM 165 type of patients as well. Then there is one patient with ARCH6 CDG which completely stopped seizing. Like, it was just, maybe it's coincidence, but she totally stopped seizing on the galactose. But that's a number one, so that's not research. It's just starting to collect data. And then there are 2 other specific CDGs which showed very good improvement in their seizure control. So actually what we try to do is to have more patients and evaluate them. It's a short study, and we only go for significant improvement. Because it's still, a lot of, that's really taking galactose every day. That is, it's treatment. It is an effort. Okay, so we will hear about this. And now I finish up. With what's coming up next. So actually, I'm sorry, I'm moving too much. Actually, we will talk about 2 other treatment options today. You can give sugars in the diet, and then maybe those sugars will change your glycosylation and you improve. But theoretically, you can also give activated sugars to your diet, which are already ready to get built into the glycan chains. So you don't have to go through all the steps. You activate your sugar and it goes in and it does its magic. It's only risky because that activated sugar, who knows where it goes. So you have to figure out the good idea how you put that activated sugar in a container and send it to the right place where the glycosylation works. So that would be one idea for treatment, and we'll talk about this pretty soon. And the other idea would be to bring in the enzyme, the missing enzyme, which is making the step of glycosylation. That's a very tricky therapy. We do that in several disorders, inborn errors, but we don't have a really similar disorder we could cheat on to see how could we make this happen. Because most of the disorders using enzyme therapy are lysosomal disorders. That's another compartment of the cell. You can target your enzyme to those vacuoles and then they work fabulously. But in our case, it's a much more complicated issue, and also the issue how you would send the enzyme to the brain, because you want to take care of the whole body and not just coagulation. Okay, so these are therapeutic options. And then the next, so these are 2 patients who couldn't come, and then at least they can be with us for a moment. This is actually the infusion room where we'll have the patient's social tomorrow during patient visits, where you can camp out and talk, and the children can play. So this was tough. I know it was tough. We will repeat some of the ideas, some of the slides. You will see they will come back again and again. So at the end of the day, you'll be a fully trained sugarologist. Do you have questions at this point? Or can we just move on, and then probably you'll have plenty of questions around lunch? I mean, I'm happy to answer questions now, but maybe you want to learn a little bit more about the biochemical background, then it's over, and then we will switch over to therapy.